welcome everybody to Medical Grand Rounds. I'm excited to introduce our Vice Dean of Education, Catherine Lucy, and a new title of Executive Dean. Executive Vice Dean. And also heavily involved in the Differences Matters initiative here at UCSF. So I thought I had Dr. Lucy sit down because I've got a little bit of an introduction to give, and it's really quite a long story that you've had over the years. I'm going to abbreviate things, but so start with medical. I'll start there. Medical school, Northwestern, and then came to UCSF for her internal medicine residency, stayed on at San Francisco General Hospital for her chief residency year, and then off to a series of places doing various jobs, including Harvard, San Antonio, and then settling, I think, in Washington, D.C. with several jobs, including Walter Reed. I call it useless, the military academy, medical school there. And then getting into the education world at Washington Hospital, first as an associate program director and then as a program director. Then things started taking off. In that time period, writing a lot, lots of journal publications, lots of presentations. In fact, just filling up pages and pages of a CV. Then the key break was getting recruited to Ohio State as the program director there, a larger residency program, and the vice chair of education in the Department of Medicine. I think that was 2002. Then 2007, becoming the vice dean of education at Ohio State. So quite a career going on there. In the meantime, she's active in a ton of organizations, societies, the Society of General Internal Medicine, APTM, our residency program national organization, and then onto the ABIM in a leadership role there. So tons of stuff happening, and then 2012, we hit pay dirt here at UCSF because we recruited you to come to be our Vice Dean of Education here at UCSF. So, you might have thought that would be kind of a terminal job. You can kick back, just, get ready for retirement, get your 5 years for UC retirement, and you're good to go. No, she starts a massive overhaul of the School of Medicine curriculum, what we now know as the Bridges curriculum. In addition, becomes active, as you know, in the Differences Matters initiative, and just putting us on all of these new courses here at UCSF. So incredible. So fantastic leadership and all of this wonderful stuff. But what I want to emphasize is what is not emphasized, what I just told you, is her role in mentorship, which I think is extraordinary, and I think you're defining attribute that is just makes UCSF such a better place. So when you think about the journey that she's had, you could have gone solo and not taken anybody with you, but I think the defining thing about you is getting people involved and helping people with their careers. So when you get that call from Catherine and she asks you, are you interested in a stretch assignment, which is one of her favorite things, please do say yes, because it's extraordinary working with you. Your mentorship, your generosity with your time, your compassion is just such a special thing to actually personally experience. And we are all so much better here at UCSF for what you have given us in the mentorship you've provided. So we should have your assistant now stand by for phone calls to make appointments. But without further ado, please tell us about the Bridges curriculum.
Thank you, Pat.
Yeah.
Thank you, Pat. That's a humbling introduction. I found myself thinking that those people are probably thinking that woman can't keep a job. It's been a good ride, and UCSF really has been my dream job because of the depth of talent and the amount of creativity and collaboration that exists here. The chief president's asked me to say why I got interested in this topic, and so to do so, I actually have to confess something. It's not something I like to talk about very often, but since I'm among friends, I'll be honest about this, and that is I was a biochemistry major. That's what I'm confessing. My mom was a chemist. My dad was a chemist. And I have to say that every time I love biochemistry. I love most of basic science. We won't tell you the ones that are less favorite on mine. But every time I hear a resident or faculty colleague say, I don't know why students have to learn basic science. Nobody ever uses the Krebs cycle. I die a little bit inside. So I decided a few years ago, like the good UCSF residency trained person that I am, that I should look into the evidence and see whether in fact it's true that people really don't use the Krebs cycle once they graduate from medical school, or actually no, once they take USMLE step 1. And so that's what I'm going to talk about today, what's basic about science and medical education and how we've used information around the role that basic science plays in the life of superb physicians in a structure to help us design the Bridges curriculum. Many of the people in this room have been Bridges curriculum innovators, and I will thank them now and thank them at the end. But today we're going to talk about the role of basic science in medical education. These are the disclaimers. There's no conflict of interest for educators. No one pays you for anything that you do. But as those of you who have heard before us talk about the curriculum, we designed this curriculum to be uniquely relevant to UCSF because we think there's a special sauce here that people acquire being a medical student or a resident that makes them very distinct in the way they approach patients, problems, and populations. And one of the elements of that distinction is this relentless focus on science and the importance of science in taking care of patients, both applying today's knowledge as well as working to advance sciences in multiple disciplines. So for those of you who are midway through your burrito and might take a little nap, let me start with the conclusions, and then I'll sort of hopefully convince you of these conclusions by the end. There is plenty of scientific evidence, empiric as well as theoretic frameworks that prove that scientific principles and concepts are fundamental to understanding and addressing issues of human health and human disease, and as such are essential to any physician who wants to actually be at the top of his or her game in this environment. But adherence to the traditional framework of what we knew in the 1900s as basic science, and also contrasting that rather than integrating that with clinical science or clinical care, is not aligned with what our evolving understanding is about the causes of disease in the diverse sciences we need to alleviate suffering for our patients and our communities. So we would propose that medical education needs a new framework, that of the foundational sciences, to reinforce the principle that all who seek to advance health and address human suffering have to understand and advance the critical interdependencies of sciences across the spectrum from molecular to society. And in fact, science in the field of education or pedagogy can help us guide our work. So today we're going to talk a little bit about the forces and opportunities that are driving changes in the roles that physicians assume and thus in the sciences we must be prepared to embrace, summarize the literature on the way that the basic sciences play out in learning and clinical care, demonstrate the relevance of foundational sciences in solving our most complex challenges, and then talk about how we're practically applying this in our curriculum and how you might actually practically apply this in the teaching that you do with your students and with your residents and colleagues. So when Flexner first ushered in the first era of medical education in the early 1900s, his major principle was that medical education should no longer be an apprenticeship, but should be embedded in the academy, in the university. And thus he defined the basic sciences really very structurally. That is, the departments that existed in the university that taught biology, physiology, pharmacology, anything that might be relevant to understanding disease in the early 1900s. Now, this was really a focus on both discovery and specific disciplines because there was this incredible belief that based on the recent establishment of the germ theory as highly relevant to the environment that they were working on, that there was going to be an elegant sort of silver magic bullet that people would be able to discover through their work with patients that would help explain every disease that was causing suffering. And countering that, there would be a simple and elegant solution. And it's not illogical to think that way based on the dominant way in which science was viewed, quite reductionist at that time. And after all, some of the early successes really did look like that. Insulin for diabetes, penicillin for gonorrhea, and then a little bit later, a vaccine to prevent polio. I'm always fascinated by this gonorrhea picture. Can you imagine having so much gonorrhea that you would put a street sign out to help people? Just think about that culture for just a minute. So that actually also ushered into this belief that the physician was not just responsible for caring for patients, but was supposed to move back and forth between patients at the bedside and bench to discover and contribute to advancing science for medicine. And when most of the discoveries were in anatomy and physiology, it was very easy for the practicing physician to sort of take their observations and sometimes bodily fluids from their patients at the bedside and turn those into advances in medical profession. Now, as science advanced in the 20th century, we began to move beyond those preliminary departmentally based disciplines like anatomy or physiology or pharmacology, add new sciences like immunology and genetics. And there was a move then sort of towards the end of the 20th century and the beginning of the 21st century to define basic sciences more functionally. And Finnerty in this article in Academic Medicine actually nicely described that as the basic sciences that were needed, whatever it was, to deal with the complexities of the human body, these emphases in red are mine, and apply biologic concepts and principles in order to effectively analyze, assimilate, and solve novel and ill-structured human problems. So that was sort of a nod to the fact that perhaps we weren't going to be able to find a single solution to every problem that man faced. But you can see this is still fairly constrained in its definition, focusing on the human body, in fact, focusing mostly on biologic concepts and principles. Now, it's tempting to sort of just declare success with that approach because, in fact, we had tremendous success in the medical sciences across the 20th century. This is, there's a cardiologist here. So this is a graph from an article written by Betsy Nabel and Eugene Braunwald in the 200th anniversary of the New England Journal, which shows the decline in deaths per 100,000 population from cardiovascular disease, and you can map them very nicely to those discipline or departmentally based basic sciences, as you can identify here. You could use this same or take a same curve, and you would see it in infectious disease, in nephrology, in rheumatology. The 20th century was incredibly successful at using science to reduce suffering and improve the health of communities. But with that success came some challenges. In the first place, when you get rid of acute infectious diseases and you solve lots of those immediately fatal illnesses and turn them into chronic diseases, then you begin to have populations that are living with not one, but sometimes 2, 3, or 4 complex chronic diseases, which in fact changes that nature of science because no one just has one condition to solve at a single time. And so it already begins to look very systems-based in terms of the way we need to think about science. And then advances in both molecular mechanisms and also data science have enabled us to sort of identify that, in fact, diseases don't just arrive from one little transmutation in a gene or one little exposure. They're incredibly complex, and understanding them requires an appreciation of the interdependency, not only of biomedical causes, but as this picture from Bob Hyatt's work on breast cancer, postmenopausal breast cancer, shows there are many drivers that actually contribute to the incidence of postmenopausal, some of which are truly biomedical, but some are which are physical and chemical, some sociocultural, and some behavioral, and begins to sort of look like that linear view of science really is extremely old school, and even a disciplinary-based view of science is extremely old school. On top of that technology and the ability to measure both process and outcomes in huge systems has actually identified for us that sometimes knowing what to do does not actually lead to improved health. And so the emergence at the end of the 20th century of these very vital elements of optimizing healthcare for our populations has added more complexity to what we think physicians need to know. And those of you who have worked with our students in the clinical microsystems clerkships know that actually embedding an understanding of systems of healthcare and the science behind improvement and safety is actually part of the new Bridges curriculum as well. So with apologies to Finnerty, we've realized that, in fact, the sciences that got us here in the 1900s are not sufficient to bring us forward in the 21st century. And so it's important for us from a clarity of purpose in education and also in terms of how we as individual physicians approach our roles to really understand what do we need from a foundational science perspective if we are going to be successful in achieving our goal of alleviating suffering from our patients and improving the health of our communities. And so we would propose and have used in the Bridges curriculum the concept of foundational sciences of the 21st century. And adapting Finnerty's work said we not only need to deal with the complexities of the human body, but the human mind, apply biologic and other scientific concepts and principles in order to effectively analyze, assimilate, and solve novel and ill-structured human and human systems problems. Now, it's one thing to say we're going to redefine the foundational sciences, and it's another thing to actually take that definition and apply it in big organizations, both educational and clinical. And what we have found is as science has gotten more complicated and complex, referencing back to that Bob Hyatt picture, which he's not really happy that I'm showing that as a manifestation of complexity, but I think it really accurately represents that. What we found that what used to be embedded in that single physician, recall the person who was going to move back and forth between bench and bedside and discover their own truths in biomedical sciences, doesn't exist anymore. The integration, for the most part, of science, clinician, and educator, which used to be prevalent until towards the end of the 20th century, now has given way to much deeper expertise in each area and a targeting of many careers, with the exception of physician scientists who still manage to sort of straddle canoes in many different environments. But that lack of understanding of what all of us do, but the clinicians not necessarily understanding what scientists do and vice versa, has caused some sort of turf wars that we hope to be able to solve by just being more explicit about what we need. Foundational scientists sort of saying, as they see clinical work moving earlier in the curriculum, you're eliminating room for basic science and dumbing down medical school, and then the clinicians on the other side seeing basic science come into the clinical environment, asking that really horrifying, why do I need the Krebs cycle question once again. And so what we want to sort of start at this point is talking about, from the same shared mental model perspective, why do we think science is important, and how are we going to make sure that the graduates from UCSF School of Medicine residency programs are the type of physicians we need with the foundational sciences used on a daily basis to support patients. So let's first develop that understanding that science is essential to the high-quality physician. There is plenty of empiric evidence, and I'll summarize some of the more salient articles here, that scientific concepts, particularly causal mechanisms of disease and therapeutics, are essential for people to understand clinical reasoning and to connect patient concerns to logical diagnostic and therapeutic plans. Causal mechanisms are really the glue that holds these concepts of clinical reasoning firm in a physician's brain and makes them accessible when needed in the clinical environment. So let's look at some of the data. Woods and colleague, Nikki Woods and colleagues, and Nikki was here last year, have done several really beautiful studies that demonstrate that medical students who are provided biomedically causal information show much greater accuracy for neurologic and rheumatologic conditions than those who are provided just probability information. So what this means is, don't teach your students that 15% of patients with ankylosing spondylitis have HLA-B27, but talk about the role that HLA-B27 has in the origins of ankylosing spondylitis. Simple causal explanations allowed students to perform better on speeded tests than their counterparts who were provided only with lists of clinical features. So just memorizing in the books of first aid for the boards and things like that might get you through those tests. But in fact, if you really want to develop expertise, linking those symptom lists with the causal mechanisms of why those symptoms exist in a given condition is much more likely to lead you to expertise. And educators in this environment know speeded tests are a marker of expertise, right? So if you can do something accurately, quickly, it's sort of a marker that you've advanced beyond a level of simply competent. And equally important for test taking as well as for caring for patients is causal mechanisms improve students' ability to ignore distractors and adapt to new descriptants. So it helps the students sort of navigate through some of the noise that exists in taking clinical histories, but also the distractors that exist in taking standardized exams. So that's good for learning, and let's just say that, but what about clinicians? And what about people who are already mature and in their clinical, the phase of their lives which they consider themselves to be experts? Well, originally, when we looked at this back in the 90s, there were several authors who were trying to respond to that question of or statement that clinicians don't use basic science, and proposed several theories that basically said that your understanding of basic science sits in one part of your brain and your understanding of clinical reasoning sits in another part of your brain, and never the twain shall meet. So that was actually a very dominant theory for about 10 years, but subsequent work, both empirically and theoretically, has shown that, in fact, that's not the case, that experts in medicine and clinical reasoning store core features of causal mechanisms, pharmacologic issues within their illness scripts of how the disease presents. So you can imagine that every single understanding of your disease is centered around a core of pathophysiology, anatomy, pharmacology, anything that science that's relevant. And on top of that, experts layer the features of their disease so that it is accessible at some point. It may not be right on the surface, but it is accessible when you need that. And in fact, experts' ability to use biomedical knowledge and tendency to use biomedical knowledge in clinical reasoning has been shown in several studies. One just testing how quickly clinicians can recall biomedical phrases and examples from recent clinical cases suggesting that encapsulation of biomedical knowledge and clinical features exist. And also, and I think the experts in this room, and I see many, will recognize that when you're faced with a challenging case that doesn't in fact seem to fit any established pattern, experts clearly resort to biomedical reasoning, and this is some of the work that Jeff Norman and interestingly the person who originally said it wouldn't, who's Patel, exist. Even more interesting information becomes when you begin to test physicians about their recall of basic science. So here's information, or here's data that comes from Clusters and Tim Cott. Tim Cott, for those of you who don't know, is a faculty here, also at the University of Utrecht. Dave Irby, I see in the back, was able to successfully convince him to partner with us. Show that experienced physicians retain basic science information for a very long time, much longer than anybody had anticipated. For example, practicing physicians 40 years post-graduation in these studies still had accuracy on exams that was about 75% of the people who just finished the exams. Now, okay, somebody's going to say, but look at the people who just finished their exams, they only got 40% right. That's not a problem with not use of basic science information later. That might be a problem with how we teach acutely. But the curve is pretty flat, and most people did not think it was going to look like that. The other thing I think is interesting about these two curves, again, they go out 45 years, is that look at anatomy. So anatomy is the one where people remember most. And I'm still trying to figure out why anatomy is so better retained than, say, physiology. They didn't ask about the Krebs cycle, but it's in there someplace. Even more interesting is even information that you say, I don't even use that, right? And so we get this all the time. It's like, you shouldn't test me on that because I don't even see cases that are relevant to that basic science concept. and then we call that, or they've called it unrehearsed or ostensibly unused knowledge, also appears to be retained at some level. So even if we couldn't sort of connect you up with a case that should have stimulated your thinking about the Krebs cycle. The first part of this curve looks like what's known as the Ebbinghaus forgetting curve. You probably are familiar with that, not as a person, but maybe as a scholar, right, that people do forget things, and it sort of takes this nice little sort of elliptical curve there. But it never goes below sort of a certain level, and that's actually compatible with this theory, which is the permastore theory. And the permastore theory basically says that things that you learn well in your childhood, early adulthood, or during formal education actually is always there in your brain and can be activated when you need it in a particular circumstance. And the examples they use a lot are, last time I took French was 8th grade, and yet somehow when I'm in Paris, I can read the signs. You know, so another deep permastore theory, or I kind of call it permafreeze story, is that is you can use math that you never used to use, right? All of a sudden you need calculus, and somehow you can understand that equation that's sitting in front of you, even though I really haven't looked at a calculus equation in a long time. So I think science is foundational, and it actually has a lot of empiric evidence shows that people who are expert clinicians use science. So if we see that point, and you can argue with me whether you think I made that point later, but if sciences are foundational, which ones and what about them is foundational? So medical problems in the 21st century, as I mentioned, are complex and are going to really require unprecedented learning and adaptability by physicians over the next 20 years. These are things that are coming at us, and we actually have to be able to prepare our learners to continuously learn. That is the challenge of the 20th century. It's not about memorizing today's factual information. It's about figuring out how to get information and learn with that information over the next 40 years of your careers for people who are just starting out. Massive amounts of data, some coming from the electronic health record, some coming from open access to scientific data that exists in the literature now, some coming from our patients who are wearing continuous monitoring of their heart rates and blood pressures, and are going to be bringing you lots of information that we'll have to sift through and figure out how to use. Relentless prevalence of chronic disease changes the way other new diseases look. We don't have a great understanding of what Wegener's, well, we don't call it Wegener's anymore. We call it something with polyangiitis. Granulomatosis with polyangiitis, close to that? Yes, it just shows my age. That's a permastore thing. You just saw that, right? The permastore thing. We don't know what it looks like in somebody who already has diabetes, hypertension, coronary artery disease, chronic obstructive pulmonary disease, and perhaps a little rheumatoid arthritis, right? So the way we think about diseases as isolated pure phenotypes is going to change. Changing models of science and characterization of disease, the biggest example that we can give is we used to talk exclusively about organ-based cancer origins, and now we're talking about molecular-based cancer origins. And then, of course, changing models of clinical reasoning with the advent of clinical decision support tools and diagnostic reminder systems, as well as care delivery changes that will challenge our providers. So we have to move away from the concept that drove foundational science teaching and understanding in the 20th century, which was the physician as the knowledge repository. Because recall at the beginning of the 1900s, no one else had access to factual information. Only the physician had the books. And nobody else could get access to those books. But now everyone can. So the physician as knowledge repository is not a model that we should be emulating. In fact, we have to think about all physicians as scientists, both those who can reliably apply today's knowledge by understanding mechanisms and seeking and analyze evidence around those mechanisms, and those who can recognize and explore the limits of knowledge through asking good questions, finding or generating data, and testing hypotheses about what might be going on with your patient or with a particular population, or more broadly through the profession. So the foundational sciences we need for our providers are those that are going to prepare learners for future learning, to solve the problems that they in the profession will face. And learning from a cognitive psychology perspective means changing long-term memory. That's what learning is. How do you change long-term memory? And how do you create an environment where that long-term memory, once built, can be adapted and accessed when confronted with a novel or ill-structured human or human systems problem, as we said our definition looks at. So you have to actually be able to teach people to find new facts and concepts, think about them, which means accessing information from long-term memory that already exists, and then reasoning, meaning incorporating those into your long-term memory, making connections, and identifying questions that persist, and continuing to go through that cycle. The future learning we have to prepare people to engage in requires knowledge and problem-solving skills in multiple domains of science. As we've mentioned, not only biomedical, but clinical, translational, social behavioral, epidemiologic, and data-driven sciences, engineering, technology, and education. And just as an example of how we are thinking about this as we've constructed the Bridges part of the curriculum and inquiry, just recognizing one simple problem, not a simple problem, one complex problem, childhood obesity and adult metabolic syndrome. Here's some interesting facts that all of which actually contribute to our understanding of these conditions which are causing so much suffering and provide us with potential therapeutic leverage points as we seek new opportunities to both prevent and treat the diseases that are causing difficulties. From gut microbiome changes that increase the risk of obesity, to exposure to violence in childhood, increasing metabolic syndrome, and then other strategies that, in fact, might help us begin to counteract these negative changes that are defined by different forms of science. So what do we know about how we prepare people for future learning in the foundational sciences? Learning that will allow them to actually bring in new material, adapt it to what they know to be true already, and then reason with it on supporting their patients. So the key issue we have to focus in on is the concept of transfer. And transfer is learning that allows you to use knowledge learned in one context, sitting in a classroom, to solve dissimilar problems in another, on the wards. Or learning in a context, the ICU, that allows you to solve problems in another context, the ambulatory environment. So transfer is the holy grail in teaching about foundational science and other core elements in health professions education. And context is the other single truism in medical education, that context matters. So there is literature on this as well. The first is using analogies helps people build transfer ability. Why does that make sense? Because analogies are already telling you that a principle that I'm about to teach you about physiology or pharmacology or anatomy has connections in a different context. Car maintenance, songwriting, piano playing. So it's found actually that students introduced to biomedical concepts and rules using non-biomedical analogies had greater transferability. So that's one tip we can give to people who are thinking about teaching for transfer. A second is that providing compare and contrast examples with mixed examples really reinforces principles with a level of flexibility that enables transfer. So here's just data that shows if you teach the principle with only one example, transferability is at about 20%. If you give two examples, just here's two examples of this physiologic concept or this immunologic concept, that's a little bit better. But if you take the time not only to provide the principle and those two examples, but really deliberately establish the compare and contrast between those two examples, that gives you the best retention and the hope for transfer. Optimal practice is also significant in teaching for transfer. Mixed and distributed practice is better than blocked and concentrated practice. What does that mean? Mixed practice means that when you are reviewing your mix-up for your internal medicine boards, you should not do the cardiology questions right after you've read the cardiology mix-up. The likelihood that you will actually master that and retain that and be able to surface it in another context, sitting in a Pearson VUE Center, is much less than if you actually study cardiology and then sometime later go through the questions that are mixed and not necessarily connected to cardiology. So you mix up, some are nephrology questions, some are pulmonary questions. That's mixed and distributed rather than blocked and concentrated. And that's been shown in multiple different fields, two of which I'm showing here, one for geometry and one for EKG testing. And it's why we put such a heavy emphasis not only on integration in the Bridges curriculum, but also on revisiting concepts through our assessments and providing cumulative opportunities for people to demonstrate their knowledge. Frequent cycles of learning and using improve retention. This actually shows, what is the shape of this curve? Does anybody, we saw it earlier. What do we call that? The Ebbinghaus forgetting curve. See, we haven't gotten you to transfer for that yet, but we'll work on this. So these are Ebbinghaus forgetting curves, right? And so what you see is if you keep reinforcing, the depth of that of information that's forgotten is shortened as you go over time. And this speaks to the importance of, again, not only introducing a concept once, but recurrently introducing those concepts and reinforcing them, again, with different analogies and different contexts. And then any of you who have teenagers actually should take glee in this. And in fact, arguing to learn is a really important way of establishing the ability to fix information in your head, because it requires you to consider other people's viewpoints and thinking a little bit about how you don't just argue to sort of argue like on Twitter, but you argue with a deliberate intention of advancing claims, justifying ideas, and being challenged. And this happens best in consideration of unanswered problems with diverse groups and different sciences. That's the best way to sort of engage in arguing to learn. So what are the practical curricular applications? We've sort of touched on a few of them, but I want to sort of talk specifically about some very great examples that your colleagues have put together in their work on Bridges and also in the work in your internal medicine residency program. Essential science has to occur throughout the continuum of medical education, from UME through GME. And we do this in the clinical microsystems clerkship with science embedding the patient safety and quality work that the students do. And I will talk in a minute about foundational science and Foundations 2 days that Pat Cornett and Heidi Cornish have been directing. Assessment must be progressive, cumulative, and goal-directed, and sort of focused on those mixed and distributed practice. You may not know, but all of the medical students now, their formative and summative assessments are open-ended questions. They do multiple choice questions just to practice for the boards. But the open-ended question actually allows them to really work with the material and engage with it in a way that actually demonstrates better understanding. And then arguing to learn, groups of student and faculty with diverse areas of scientific focus should meet and deliberate on challenges with unknown solutions. I think your molecular medicine consult service that Amy Berger and others have been working on is a perfect example of this. And what they've seen in preliminary cases they've looked at is how different scientists and clinicians approach an unknown. A scientist from the mechanistic perspective up, a clinician from an organ perspective down. There's values in those people sitting in the same room and talking about how their views might in fact help advance a solution for that patient. So I want to talk just briefly about the Bridges Curriculum Foundations 2 because it will be starting soon. These are the clerkship years. It used to be the third year, and now it's midway through the second year. A lot of differences compared to what you might have experienced in medical school, and your help in us making this a success is appreciated in advance. It's preceded by a diagnostic reasoning block that Denise Connor has been working on. It really helps people think more deeply about how to make sure they understand the diseases they're looking at and how to take patient information and turn it into a logical presentation. We're hoping that with the clinical microsystems clerkship, we'll send you a different type of student, one who's comfortable in the clinical environment and whose focus with you can really be on those more sophisticated clinical reasoning skills and care of the patient. It begins in January of year 2 and ends 1 year later, and it's followed then by a study period, which then is followed by step 1 and step 2, clerkship exams. And it incorporates a longitudinal family medicine clerkship, allowing for time for career exploration and skill enhancement, and includes a full academic day every other week for foundational science spiral learning. So this is a sample block that Leslie Hsu and Pat Cornett and Sarah Godwin have put together. Medicine, surgery are still 8 weeks, OBGYN and peds still 6 weeks, neuro and psych still 4, but not necessarily back to back. And then the students have a minimum of 1, 2, 3, 4 elective blocks where they can take on either a skill-building activity, a subspecialty career elective, or an integrative elective that, and I think Sarah and Leslie have done a remarkable job putting these together. The FS and F2 curriculum is the academic day for the students, and this will require you to believe and to support the fact that students can learn internal medicine in 5 days a week. They can learn internal medicine in 5 days a week. 60 hours of clinical work is enough for them to understand the field that we need to have them understand. And the reasoning that they'll do during these Foundational Sciences Day, we hope will translate into better clinical reasoning for the students as they're on all of their rotations. The curriculum has been designed by Pat and Heidi with consultation from experts at UCSF, but also reflecting the Howard Hughes Medical Institute's Scientific Foundations for Practicing Physicians document. It incorporates, the days incorporate an appropriate use of diagnostic test sections, so this speaks to using things like lab tests, imaging procedures appropriately, which is a hot topic these days, and then about 6 or 7 hours of foundational sciences and many different topical areas that have been vetted as priorities for both in terms of frequency with which the students will need them, but also in terms of complexity. So things that needed to be brought back and revisited because they're difficult to understand, those we're bringing them back and revisiting, particularly issues around genomics, coagulation, hemostasis, nutrition, and cancer immunology. So what about you as an individual? How do you use this information to enhance your practical teaching? The first is to set the right tone by words and action. It's really important to not be dismissive about the sciences that the students are learning. We want them to remain engaged with the scientific curriculum. Part of the intent of putting step 1 after the clinical year is to help them realize that scientific reasoning is critical in the clinical year. We want to move away from the old, what we used to call binge and purge of basic science education, where people learned it for 2 years, took the exam, and basically said, done with that, not going back there. And your actions, as you are reasoning through things, explicitly talking about why you know that this heart rate of 140 cannot just be a little bit of a reactive tachycardia. Talk about what's happening with a person with diastolic dysfunction that makes them so sensitive to a drop in volume. The more you can actually talk about what you recall of your basic science, the better the students will be able to do that. It's important for you as you're thinking about your care teaching scripts, and all of us do. All of us give a talk on something, diabetic ketoacidosis, or septic arthritis, or the immunology of HIV. Make sure that as you're talking about the mechanics of care for the patients in the clinical environment, what's the right care path, how do you make sure everything is done reliably, how do you get them out of the hospital by 11, that you incorporate some mechanisms of disease into that conversation. Develop non-biomedical analogies to support basic science principles. Some people are experts at this, and in fact, we have a workshop coming up for anyone interested. On November 7th, Amy Wilson-Delfas from Case Western University, Reserve University, and Gustavo Valbuena, who is one of our JMP faculty at UC Berkeley, will do a workshop on analogies to support basic science principles. When you have patients who have different presentations of the same disease, even if it's simple as hypertension or diabetes, is a perfect example for you to engage in really thought-provoking questions like, why is this patient's blood pressure uncontrolled on 3 agents, and this person can actually manage their blood pressure with just hydrochlorothiazide? Those are actually really fantastic questions to challenge your students to think about, because they're questions that are not answerable necessarily in the moment. You don't want any question that can be answered in 10 seconds or with a few taps on the iPad is not actually a really good teaching question. You want your students to be thinking deeply and thinking about what are those unanswerable in the moment questions that I can give my students, and then give them a little time to think today about it or to bring back tomorrow to discuss with the team. Importantly, also reward unanswerable questions. We had at a retreat a few years ago an incredibly insightful MD PhD student who talked about the fact that she was distressed that when she was in her PhD program and would ask a hard question that no one had the answer to, she was celebrated for her nuanced insight into the field. And when she asked the same type of a question, when she returned to the clinical environment, she was not celebrated. We'll just say that. It was sort of dismissed as not relevant. We can't answer that. We don't have time for that. And I am also thinking I've always remembered Bob Nussbaum, who said something really profound about this, that the three most intellectually divisive words in medical lexicon is "we see this." So if you're tempted to say "we see this," tell people "we've seen this," go figure out why we have. And then model management of uncertainty, and consider a scientific consult. We get consults all the time from clinicians to help us understand what's happening in our patient. If we don't understand the molecular issue, this is where your molecular medicine consult services is perfectly poised to provide some insights, or dare I say, find a physician scientist or an MD PhD student and ask them to come and talk about a case from the molecular perspective while you talk about it from the clinical perspective. So with that, I'm going to come back to my conclusions and hope that I've convinced you that science is, in fact, fundamental to understanding and addressing human health. Thinking about our work as basic scientists versus clinicians is not a good thing. We should be thinking about clinicians and basic scientists working together to advance human health, not only for the future, but for the patients right in front of us. And a new framework of foundational sciences implemented in evidence-based ways, both through curricula and individual learning and teaching experience is likely to be the right way to go. So I'll stop there and ask for any questions, but also thank all of the people who've been so incredible in the work we've done in Bridges.